Well, hello, thanks for having me here. My name's Evan Schwartz. I'm an emergency medicine physician at Washington University and the section chief of medical toxicology. So we're going to be talking about some toxicologic issues that you all may run into. And as I'll also bring up at the very end, if you have any questions at any time point or any other topics you'd like to hear about, just please let me know and we'll work something out. So I don't have anything to disclose. So we'll start with kind of the first case where you're called upon the scene and you pick up about a 45-year-old gentleman. The complaint was for respiratory distress, and you notice small pupils. Towards the end, we'll get to kind of what we classically think about with small pupils these days, unfortunately. But this patient also had small pupils. You notice a lot of frothy stuff at the mouth, and as you're trying to figure out what's going on with him, he actually starts to seize. And so this is actually a cholinergic or a muscarinic toxidrome, and so that's the first area that we'll start with today. So this is part of the toxidrome. We'll go through the rest of it. For those that aren't familiar with the word toxidrome, it comes from a combination of toxic and syndromes, and really the whole idea is to try to put together a bunch of signs and symptoms a patient may have to try to figure out what they may have been exposed to, at least a class of agents they could have been exposed to, and then figure out what steps I need to do to start treating this patient. So classically, when we think of cholinergic or muscarinic toxidromes, we think of the organophosphates, and unfortunately these days the first ones we think of are these weapons of kind of mass destruction, the nerve agents. So classically your tabin, your sarin, your soman, and your VX gas. Even though they're called gases, they're not truly gases. These are going to be actually vaporized liquids or very viscous substances, which we'll get to. But remember, we're in the Midwest. We're not too far from kind of farm country. And there they can have a lot of very highly toxic organophosphates. In the city, you're not really going to run into those. The stuff you buy at a store is going to be much safer stuff. They're going to be products a lot of times made from chrysanthemums. There are some kind of dangerous things you can get into, but as far as the dangerous organophosphates that we're going to be talking about, those are going to be more in the farming community, or they're going to be someone that's a licensed exterminator that has pesticides and can get to some of these more harmful substances. But as I said, a lot of times what we worry about is more weapons of mass destruction. So these are a couple pictures from sarin exposures. So in the 90s in Japan, there was a cult that actually was releasing sarin. They did it a couple times. These are some victims from one of the episodes. These are victims that were actually from a subway attack. So what they did is they actually had people go on a subway, drop a balloon, and pop a balloon. And it was full of sarin, which actually vaporizes pretty quickly and pretty easily, and people were exposed to a bunch of sarin. Unfortunately, some first responders were also exposed to sarin, poisoned a lot of people. Fortunately, only about 12 people died, if I believe. This is the ringleader to the cult, and actually I believe they were just executed not very long ago for all these kind of terroristic and horrible events that they did. Since then, more recently, we've seen some of these exposures in Syria, unfortunately. If you go ahead and Google, you can see lots of pictures. Unfortunately, people that died had this very classic frothy at the mouth type of appearance from the organophosphates. And then as far as VX, which kind of people hear about maybe more on the news and on TV shows sometimes. Recently from North Korea, we did have Kim Jong-nam, and we'll show the video a little bit later, and he was poisoned with VX. Basically, they put it on a cloth and put it on his face, and within probably 20 minutes or so, he was actually dead. And then we've had some other exposures to VX as well. There was some exposure theoretically, or we believe, from the Russians. This gentleman and his daughter, Sergei Skripal, he was exposed to what we believe was a newer agent that's very similar to VX type gas. And he was on his park bench with his daughter, and he was exposed to something. They both ended up going to the hospital, and it was found to be a Novichok agent, which we'll get to what that is. But to give you an idea how persistent this was, at least a month or two later, someone else happened to pick up something that still had some of this nerve agent on it, and they actually got poisoned and ended up in the hospital as well too. So it can be very toxic and very deadly type of stuff. And how all these things work is they end up working on the autonomic nervous system. And what your autonomic nervous system is basically the nervous system, the part of your body that keeps it functioning without you thinking about it. So if you think of it, sometimes we can do things to kind of control our heart rate, but normally we're not thinking second to second, like I need my heart to beat, I need my heart to beat. Your body does that kind of automatically for you. It also kind of sweats in a lot of situations automatically for you, and that's the autonomic nervous system that controls it. And the autonomic nervous system is run by acetylcholine, which is right here. And what these organophosphates and nerve agents do is they deactivate the enzyme that deactivates acetylcholine. So it's kind of a negative to a negative creates a positive. So they don't let your body break down acetylcholine, so you get an excess of acetylcholine, and that's why these things are cholinergic. And specifically, we talk about muscarinic because this is a part of the body system where they act on. But just to give you kind of a brief overview so that this hopefully all kind of makes sense, you get all this acetylcholine release. It can be released in your brain, which is why some people get seizures. It's released here in the first step, both on your sympathetic nervous system and your parasympathetic nervous system. And these kind of play against one another to keep your body in balance so your heart rate's not going too fast, but at the same time your heart rate's not going too slow. It kind of keeps you nicely right in the middle. And so you get acetylcholine released. And then the next step is you can either get things like norepinephrine and epinephrine released on the sympathetic side, or you can get kind of the muscarinic side, which we'll get into as well. What's not shown here is acetylcholine is also released at your neuromuscular junction, so that's what causes the muscles to move and everything. And that's where paralytics work. So for instance, the paralytic succinylcholine is basically two acetylcholine molecules put together, and when you get it super stimulated at the muscles, you actually get paralysis. So that's how succinylcholine and some of the paralytic agents work, and so that's why you can get some paralysis from some of these nerve agents as well too when we get there. So that's kind of a basic background, but what it does here are kind of the symptoms that you can get in the organs that can be inhibited or stimulated by some of these things. So once again, this is the sympathetic side, this is the parasympathetic side, so you're going to get acetylcholine released at those nicotinic receptors, and then if it's your parasympathetic side or muscarinic side, those are the muscarinic acetylcholine receptors that are activated, and so you get small pupils, your heart rate slows down, your airways get constricted, things like that, which we'll talk about, which are some of the classic signs and symptoms you'll see with, for instance, organophosphate exposures. But if you're trying to run from a dinosaur, you actually get the adrenaline and norepinephrine released, and so you get big pupils, heart rate goes up, things like that. But we're going to end up kind of focusing on this side here. Now that's a whole lot to remember, and I have trouble remembering it, so I try to stick to some mnemonics that are pretty easy for me to remember. So when you're talking about cholinergic toxidromes, because once again, when you stumble upon the scene or you're called for it, you may not know the patient was exposed to an organophosphate or anything else like that. You may just be able to look at them and put these things together and say, hey, this sounds a lot like they could have been exposed to a cholinergic agent. So the mnemonics we like to use are either sludge and the killer bees or dumbbells, which is a combination of that. So sludge stands for salivation, lacrimation, urination, diarrhea, or defecation, GI upset, or emesis. So the easy way to think of with this cholinergic type stuff is fluids are coming out of every orifice possible. So they're coming out of your mouth, so that's why you have all those pictures of kind of the frothy sputum around someone's mouth. They get bad pulmonary edema, they're vomiting, they're having diarrhea. Everywhere you can have fluid come out, you get fluid coming out. With that said, people don't, urinate to death most of the time. So even though that's classically what we see and what we recognize, it's the killer bees that actually kill people. And the killer bees are the bronchorrhea, bradycardia, and bronchospasm. So these people die from a respiratory death. Basically, their lungs full with fluid, their lungs also constrict just like in asthma, and they can't breathe, and that's what causes them to die. Dumbbells is another mnemonic that you can use, so diarrhea, urination, meiosis, which we'll get back to, bradycardia, bronchorrhea, bronchospasm, emesis, lacrimation, salivation. So this kind of combines both of them. This is a picture of the killer bees to help kind of keep this in mind for people. So any old Saturday Night Live fans may recognize the killer bees from Saturday Night Live. But one quick mention of meiosis. It's important. It's actually a finding that a lot of people use. So some other areas where they're more concerned about kind of these weapons of mass destruction, these nerve agents being used, and there's bombs coming off. Some of them may have nerve agents, and they get a bunch of people rightfully coming to the hospital because they're very concerned, and they otherwise look well. They'll use the meiosis, so how big their pupils are, to try to figure out if people are just scared versus really poisoned. And so with organophosphate exposures, you're going to get the meiotic, very small pupils. And so people use that as a sign, yeah, maybe they're not showing any of the things we worry about that are going to kill them, but they could have been exposed. We need to get them back to treatment. So in some ways, that's a nice way to help try to triage some patients when you're just all of a sudden have a mass amount of people that you have to start triaging very quickly, and a lot of them look otherwise well. Clearly, if they're vomiting and they're having trouble breathing, then those patients are obviously sick, and you don't need to worry about just looking at their pupils. But those are some of the mnemonics that we classically use to try to keep this all in mind. Now, we did briefly talk about the nicotinic, which is the opposite side, and sometimes you can get kind of a mixture of these things. So the mnemonic for the nicotinic symptoms are the days of the week. So Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. So mydriasis, so big pupils, tachycardia, weakness, once again, because you're stimulating the muscles so much from the acetylcholine that you start getting weakness and eventually paralysis, just like how succinylcholine works. You can get elevated blood pressure, so hypertension, fasciculations, seizures, things like that. So sometimes things can be not quite so clear cut. Where you might see the nicotinic toxidrome more is from people that are farming tobacco. So this is called green tobacco syndrome, and basically they get these plants get wet, and the tobacco then gets on someone's skin, and they can actually get really sick. Most people that work in these fields know to wear long clothing so this doesn't happen. So the more common area where we may see it is where a child gets exposed to nicotine. So classically we're seeing this with a lot of the vaporized nicotine fluid. People would like to put that into cups and put it on nightstands and tables, and it looks, it's bright green or red or orange. So a little 3-year-old goes, oh, this looks awesome, goes and either gets it on their skin or drinks it, and it gets all absorbed, and they actually can get this nicotinic toxidrome. So once again, bigger pupils, tachycardia, they could have seizures, could feel really weak and out of it. So things like that. But once again, classically with these organophosphates and weapons of mass destruction, we see more of those parasympathetic, muscarinic, cholinergic type symptoms. So once again, the sludge and dumbbells, but occasionally you will get a little of these nicotinic things mixed in there sometimes, just because life just isn't that easy where everybody presents exactly the same, unfortunately. So once again, this is just a little bit about these agents so that you kind of understand a little bit more about their history. So these are the G series originally, the Tabin, Sarin, Soman, and these were actually developed initially by Germany. They were meant as pesticides, so organophosphates for pesticides. So just like what we were using in the farming community, they were meant for that. And then Germany took these and realized they were really toxic and started exposing them to people and using it for that. So that's why they have these names here, GA, GB, GD, because they were originally developed by Germany at different points in the Second World War, or right before the Second World War. Then the V series, which VX comes from, but there's multiple V agents, were actually started to be developed after the World War II. VX was actually initially started to be developed in Britain, and then eventually British decided that this was just too dangerous to use for anything, and actually traded this technology to the United States, and we gave them some other technology. But that's where kind of VX comes from. It's more potent than a lot of these agents. These are less potent than the V series, and these are actually very viscous and stay around for a long time. So once again, going back to that example of that guy on the park bench, that stuff persisted in the environment for months, so much so that someone else was able to touch it, and they eventually got really sick as well and ended up in the hospital. So these are very persistent agents, very viscous. They stay around in the environment, and they don't go away very readily. And then the newer one, I apologize, wasn't VX that the person was exposed to. It was the Novichok agent, which is very similar to VX, but more potent than that. So this stays around for a long amount of time, and these were developed in Russia. Novichok stands for new guy, is what it means in Russia, from my understanding. Very much like VX, once again, very persistent in the environment, so much so, once again, that months later people can be exposed to it. And then it's more potent than the VX gas, which once again is not exactly a gas. And so these things are blamed for a lot of things. One thing they don't do, if you watch the movie The Rock, they won't peel off your skin or anything else like that. But this is what one of these agents can do. So this is VX. And so this is Kim Jong-nam. And this is when he was assassinated in the airport. And you'll see how quickly it happens, and also how little it takes. It doesn't take a whole lot, and I'll try to kind of talk you through some of this as it's happening, but I feel it's sometimes good to kind of see these unfortunate things to get an idea of how toxic they are. So that's him kind of walking through, and they'll show some videos, some closer-ups later, but this is basically one of the ladies that went up with just some of the VX on a rag and just rubbed it very quickly on his face. So we're not talking about a very long exposure, a very quick exposure. And she was wearing gloves, I believe, and quickly went away and washed them off. And so that's how she ended up doing okay. But as you can see, very quickly, only lasting for a couple seconds, and just wiped it on his face. And even with that, he's initially okay. So he's talking to the authorities here about what happened to him, saying he's already starting not to feel so well, maybe feeling a little bit dizzy, but that he was kind of assaulted and doesn't really know what happened exactly. And so now they're taking him to be seen by one of the clinics. So you see he's still walking around, still doing okay. They take him to the clinic. And then very shortly after that, he has a seizure and basically dies before he makes it to the hospital. And so he just sees there, and you see him getting medical attention now. So the biggest thing is, even though these are sometimes called gases, they actually need to be decontaminated. Pure gases, you don't need to decontaminate. You just need to move the patient from the agent. And if you think of it like oxygen is a gas, if you spray someone with oxygen, the oxygen doesn't stay on their clothes. It's not like then someone can breathe the oxygen off of them. But these are vaporized liquids, so they can then off-gas from them and expose other people. They can continue to be absorbed in the skin, or if you go and touch them and don't have the proper PPE, then you can actually be exposed to these agents and be contaminated. So these are people that need to be washed off with water. A lot of times a very dilute chlorine substance will actually break all these organophosphate things down as well too, at least the weapons of mass destruction. Where you really need to be careful is if you put them in an ambulance and they're still off-gassing and everything else like that, so it's still coming off of them and you're in an enclosed space, you can't start breathing this in and get very sick. Another thing you have to be careful is if the person actually ingested some of this, so actually drank some of these things, and they start vomiting, the vomit will then kind of off-gas all the organophosphates as well too. So if they drank some of this and they vomit, you need to make sure the vomit is then contained so other people don't get sick from it. These patients can be very dangerous to, once again, fly in particularly, but even in the back of an ambulance, once again, they need to be decontaminated very thoroughly before you put in there, and then make sure there's good aeration. And if anybody's getting sick, stop the ambulance and then start treating whoever else may be getting sick and re-decontaminate the person. So the big thing is, once again, these patients die from a respiratory death. They're either too weak to breathe, they start having a bunch of fluid, the bronchorrhea forming in their lungs, they get a bunch of bronchospasm in their lungs. So sometimes they will need to be intubated, which you guys are very good at maintaining airway control. What you have to remember is these patients may have a lungs full of just frothy fluid. So just because you intubate them, you may just basically be putting a hose down there and start getting fluid coming out. And even with a bunch of positive pressure, if their lungs have a bunch of fluid in them, you may not be able to adequately breathe and oxygenate them because you're just pushing against a bunch of fluid. So basically the treatment is you have to do something to dry up the fluid. Now the classic thing we have is the Mark 1 kit, which has two medications in it. It has atropine in it and pralidoxime in it. Pralidoxime may or may not be useful. How it exactly works, I'm not sure that we really need to get into, but it helps kind of reactivate the enzyme that breaks down acetylcholine. The thing about that is it doesn't do anything initially, if it does anything at all. So I wouldn't put a lot of time and energy into it. The medication that helps these people is the atropine. Because remember, if you think of cholinergic or muscarinic to anti-muscarinic, so people that have way overdosed on Benadryl at two different sides of the spectrum, these patients are all at the very muscarinic or cholinergic side, so you're trying to push them towards the middle and dry them up. So you want to keep giving them atropine until their respiratory status has improved, or if they're really bradycardic, until that heart rate is improved as well too. So in these duo injectors, they have about 2 milligrams of atropine, once again about 600 milligrams of pralidoxime. For our purposes, I don't think that's super important, but they have about 2 milligrams of atropine. So you may need to be prepared to give these patients multiple ones of these duo neps. And basically what you want to do is you want to do something called atropinization, which basically means you want to keep giving them atropine until they're fully dried up and that they can oxygenate easily for you, which is difficult. If you go to the PALS algorithm and the ACLS algorithm, they talk about giving 0.02 mg per kg in an infant and 0.5 to 1 milligram in an adult. You have to keep in mind that we're not going to use those dosages that we learned in PALS or ACLS. Basically, you start titrating, as I said, until all their secretions in their lungs are dried up. You may start with 1 or 2 milligrams of atropine at a time, which is fine, and then start doubling it every couple minutes until you get to that goal of everything being dried up. Now, the problem is you can easily exhaust all your atropine. In those cases, if you have IV Benadryl, something like that, diphenhydramine, that's also useful. If you're Ambulances also come equipped with Atrovent, which is something that we'll give for asthmatics. You can use those things as well too. But basically, you need to keep giving these agents until they're all dry, and let the hospital know as well too, so that they can be prepared to start getting all the atropine they have. Because just like you guys probably have limited supply, we don't use it very often in the hospital in the emergency department anymore, so our supply is kind of limited. So you can easily start exhausting the amount you need, because some of these patients may need up to 10 or 20 milligrams of atropine to get stabilized. All right, the other thing to keep in mind is that these patients seize, so you may need to just go ahead and give them benzodiazepines even before they seize, especially someone who you're giving a lot of atropine to. I'd go ahead and just start giving them benzodiazepines so that they don't start seizing on you, and now you have an even bigger problem to handle. And this is just a picture of a weapon that had actually a bunch of sarin in these little metallic devices here. So a lot of atropine is needed for these patients, aggressive decontamination, and then you may need to give them benzodiazepines. All right, so the next exposures we're going to get to, since it's November and it's getting cold outside, is we're going to talk about things that you may be exposed to in fires. And what we're going to start with is carbon monoxide. What's difficult for carbon monoxide is it's a great imitator. As we'll talk about, it can present like anything. Classically, what we'll see is a bunch of people that seem like they have the flu. So they have headaches, they have malaise, myalgias, they're not really feeling well. However, they don't have cough, they don't have a runny nose, they don't have a sore throat, they're not sneezing a whole bunch. They don't have all those things that you'd associate with kind of the flu or a viral illness, but it's difficult because the whole family may have it, and you're like, oh, you all have the flu, but they don't have those other cough, congestion type things, just the myalgias, headaches, things like that. They tend to get better when they're away from the house. So those are other clues that it could be carbon monoxide, but it's a very tricky thing to detect. And what's also important to remember is that other things can expose you to carbon monoxide. So these are from a Zamboni a couple years ago, and then there's just other devices in the house, particularly in areas that are using heaters that aren't working, or they're using heaters that are meant for outside and they're putting them inside because they don't have heat or whatever. Those things can generate a lot of carbon monoxide as well, and you need to be careful from that. So just real quick, what carbon monoxide actually does to you, and it kind of then makes sense with some of the symptoms, is it prevents the body from using the oxygen well. So this is our classic oxygen hemoglobin dissociation curve, and basically what this is telling you is that when you breathe in, oxygen comes into your lungs, diffuses into your bloodstream, binds to hemoglobin, and then the hemoglobin takes the oxygen to your tissues and offloads it there, and your tissues can use the oxygen, and that's how your body works. What carbon monoxide does is it lets the oxygen bind to the hemoglobin, but then it shifts it to the left. And what that means is the oxygen can bind to the hemoglobin, but the hemoglobin won't let go of the oxygen, so the body can't use it. So that's why these patients classically sometimes, and we'll talk about it, they can present kind of reddish because they're not hypoxic, because the problem isn't getting oxygen in, it's being able to use the oxygen. So carbon monoxide prevents you from using the oxygen. Whatever oxygen gets in is not allowed to be released from hemoglobin. So it shifts this to the left. In addition, it goes and poisons the mitochondria or cells directly. And then another thing it does is it poisons your cardiovascular system. So it causes it to vasodilate, so your blood pressure drops as well too. So it causes a bunch of things that even though you're giving these people oxygen, their body still can't use it and it doesn't work very well. And your standard pulse oximeters don't work as far as picking them up. So someone can have a ton of carbon monoxide in their system, and if you get your standard pulse oximeter, you're going to get a pulse oximeter of like 98% or whatever else, as long as you're breathing for them. Because once again, the problem isn't your oxygen getting into your body or getting to the hemoglobin and dissolved into the blood. The problem is that your body can't use any of the oxygen. And what your classic pulse oximeter does is it looks at the wavelength for oxyhemoglobin, and then looks at it for oxyhemoglobin and deoxyhemoglobin and just makes it a percentage. But the classic pulse oximeter can't tell the difference between oxyhemoglobin and carboxyhemoglobin, so it just thinks it's all oxyhemoglobin. So that's why you get these pulse oximetry readings of 98%. Now, what I think most of you nicely have is these newer devices that have gotten better and better and better, and they can differentiate the amount of carboxyhemoglobin in there, so they can actually give you a carbon monoxide value using those as well. So if you have one of these newer detectors, these can be really useful to see what someone's CO level is, because once again, if you just use your classic pulse oximeter, you're not going to be able to pick up that they have carbon monoxide poisoning. And what's hard is the symptoms can be anything. Classically, we're going to start with organs that really need oxygen. The oxygen-dependent organs, the ones that are more metabolically active, so going to need more oxygen, are going to be the ones where you have symptoms first. So that's going to be your central nervous system and your cardiovascular symptoms. So you think of the brain and the heart where you're going to have symptoms first, and that's why you can start developing headaches, have a hard time breathing, eventually have syncope, dizziness, you can get arrhythmias, you can get stroke-like symptoms. So all those types of things can happen because those are the parts of your body that use the most oxygen and so have problems first. So once again, you may read a lot about this cherry red skin. Once again, underneath this idea that you have all the oxygen in your body, so you're saturated well and can't use it, and so that your skin may look a little cherry red. The problem is we don't really see this very often, and when we do, they're normally just about to die or they've already died. So it's not a very reliable finding as far as to say, oh, this person does or does not have carbon monoxide. You may also read about kind of these cutaneous bullae. Some people just classically call these things barbiturate blisters. Anything that is a sedative can kind of do it. Once again, that seems to be a finding that we may find when they die and everything. So the blisters and the red skin are not something that you can reliably use to say, oh, this was definitely carbon monoxide poisoning. So the treatment is pretty simple. If they're in a house fire and have other wounds and things like that, then we go ahead and treat those with whatever we need to. The big classic thing we need to do is give them oxygen, and we want to put them on a non-rebreather and give them as much oxygen as possible, even if your standard pulse oximeter looks okay. And the reason that we want to give them a bunch of oxygen, it decreases the half-life of the carbon monoxide, how long it lasts. So the sooner you can get them on a non-rebreather and the sooner you can get them closer to 100% of oxygen going into the system, the sooner that the carbon monoxide is going to leave their system. And what we're really concerned about is the longer that carbon monoxide is in their system and the higher the level is, the better chances possibly that they could have long-term permanent neurologic damage. So our real goal is to get that out of their system as soon as possible, and we use oxygen for that 100% oxygen. Some patients will go ahead and get hyperbaric oxygen for these patients as well too. It may or may not prevent some of these long-term neurologic deficits. The literature is very controversial for that, but my main message to you guys is that give them 100% oxygen with a non-rebreather, and if there's a hospital nearby that happens to have hyperbarics, great, bring them there, but I wouldn't let that determine where you're really going to bring these patients because it's unclear that really helps them, and acutely what they really need is that oxygen. So give them a bunch of oxygen and bring them to the nearest hospital where you think can treat them and treat their other injuries that they may have as well.